Okay, so good morning. I shall be speaking about miotics and Mydriatics. So Vijay Raghavan sir has already described in detail about the nerve supply. I'll just be revising it. The size of the pupil is controlled by two muscles. You have the circular muscle out here called the sphincter pupillae, which receives parasympathetic innervation from the third nerve, and the radial muscles, which you see here, which is called the dilator pupillae, which gets sympathetic innervation via your cervical sympathetic plexus. So when there is parasympathetic stimulation, you get constriction of the circular muscle, which produces meiosis. And with sympathetic innervation, you get constriction of the radial muscles out here, which produces mydriasis. So what we understand is that miotics include drugs which have parasympathomimetic action and sympatholytic action. And mydriatics include drugs which have sympathomimetic action and parasympatholytic action. So first we'll go to miotics. We already said this include two sets of drugs, that is parasympathomimetic and sympatholytic. We'll start with parasympathomimetic, also called as your cholinergics. This include drugs which are directly acting agonists like your pilocarpine and acetylcholine, and drugs which are cholinesterase inhibitors. These can be reversible like physostigmine or irreversible like dimecarium and ecothiopate, and those with dual action like carbachol. So what is the mechanism of action? So here in parasympathetic innervation, the neurotransmitter involved is acetylcholine. Acetylcholine is released from your presynaptic vesicle and goes on to stimulate the muscarinic receptor M3, producing its action. Its action is terminated by the presence of cholinesterase enzyme, which degrade acetylcholine present. Okay. So what your directly acting agonists like pilocarpine and carbachol do is it stimulates the M3 receptor. And your drugs like physostigmine, neostigmine, which are your cholinesterase inhibitors, they inhibit the cholinesterase enzyme, thereby increasing the availability of the naturally occurring acetylcholine. So I hope the mechanism of action is clear, either direct agonistic action or increasing the availability of the already existing acetylcholine. There are 5 types of muscarinic receptor, of which M3 is the one present in your ciliary muscles and iris. And the stimulation of this M3 receptor produces meiosis, it increases aqueous outflow, and it produces accommodation. Pilocarpine hydrochloride is a non-selective muscarinic receptor agonist present in a multitude of concentration right from 0.12% to 6%. And it is used to induce meiosis as needed in some surgeries like trabeculectomy and cataract. It can be used for the treatment of primary open angle glaucoma and pigmentary glaucomas. In angle closure glaucoma, it can be used to induce meiosis and prior to a laser procedure. And dilute pilocarpine, 0.12%, can be used to demonstrate denervation hypersensitivity to diagnose a dystonic pupil. And also helps to differentiate between pharmacological and neurological mydriasis, because if it is for pilocarpine to act, your receptor site must be free. So in a pharmacological mydriasis, it does not act, it acts in neurological mydriasis. Lots and lots of adverse effects, at least try to remember some of them. Regmatogenous RD because of retinal tear, cataractogenesis is there, induced myopia due to the forward shift of the lens iris diaphragm, reduced field of vision, iris cyst on prolonged use, epiphora, fibrinous iridocyclitis, which is why it is contraindicated in patients who already have uveitis. And because of the parasympathetomimetic action, all the systemic side effects like salivation, diarrhea, etc. Now this is occusert. Occusert is a reservoir of pilocarpine, which releases it over a prolonged period, and can be introduced in the inferior cul-de-sac and releases pilocarpine over 4 to 7 days. Okay. So the next set of drugs which have meiotic action, sympatholytics. So again, mechanism of action in sympathetic innervation, the noradrenaline is the neurotransmitter involved. So noradrenaline is released again from the presynaptic vesicle, goes on, attaches to the alpha receptor, alpha-1 receptor. Its action is terminated by monoamine oxidase and catechol-methyl transferase, and ultimately noradrenaline is reuptaken into the presynaptic surface. Okay, so drugs like reserpine and guanetidine, what it does is it inhibits this release of noradrenaline. So availability is reduced. And drugs like thymoxamine, it acts as an antagonist at your alpha receptor. So this is a mechanism of action of sympatholytics, but it's not very commonly used as miotics. Next, we'll go to the second set of drugs, which is mydriatics. So we said already, mydriatics include two groups of drugs. We have the sympathomimetics and parasympatholytics. We'll start with the sympathomimetics, also called the adrenergic agonists. So this include drugs like adrenaline, phenylephrine, cocaine, and hydroxyamphetamine. Their actions include dilatation of the pupil, increased aqueous outflow, and reduced aqueous production, and relaxation of your ciliary muscles. Again, mechanism of action, what your drugs like hydroxamphetamine, ephedrine does is it increases the release, stimulates the release of noradrenaline from the presynaptic vesicle. So this increased availability. Adrenaline and phenylephrine, it goes and attaches to your alpha receptor and behaves like an agonist. And cocaine, it has two mechanisms of action. One is it inhibits your monoamine oxidase, and the second is it inhibits reuptake into the presynaptic surface. Okay, so this is how your sympathomimetics act. Either increased release, agonistic action, or reduced uptake, increasing the availability. Phenylephrine hydrochloride produces both pupil dilatation as well as conjunctival vasoconstriction. It is present in concentrations of 2.5%, 5%, and 10%. Mydriasis occurs in 30 minutes, maximum action in 1 hour, and lasts for about 4 to 6 hours. It is used to induce pupil dilatation for purposes of refraction, uveitis, and before your surgeries. It is also used as an ocular decongestant very commonly and helps detect denervation hypersensitivity in Horner syndrome when you use a dilute 1% solution. Again, adverse effects include transient blurring because of the pupil dilatation, brow ache, maculopathy in a phakic patient, and because it's a sympathomimetic, you get tachycardia, arrhythmia, hypertension, very rarely stroke and myocardial infarction. Contraindications include patients who have narrow angle glaucoma. In infants, it's relatively contraindicated, also in those with cardiac disease, aneurysms, or uncontrolled hypertension. These are the other sympathomimetics, just we should know about them. Adrenaline used in 1 in 1000 concentration, cocaine in 2% and 4% concentration, hydroxyamphetamine in 1% concentration. They dilate pupil, and hydroxyamphetamine also produces minimal amount of cycloplegia. Adrenaline can be used intraoperatively for inducing mydriasis, and it is also a component of midricane, which is used in uveitis. Cocaine and hydroxyamphetamine can be used for the diagnosis of Horner syndrome. And how are they used? Horner syndrome is an oculosympathetic paresis where you have ipsilateral meiosis, ptosis, and anhydrosis. And there are 3 levels to this lesion: central, preganglionic, or postganglionic. So this diagram will help you understand where these drugs act. So I said for cocaine to act, noradrenaline should be present. So just inhibits the reuptake. So in Horner's, cocaine, there is no noradrenaline. So naturally, cocaine does not act. Okay, so Horner's pupil will not dilate when you give cocaine. Why? Because noradrenaline is not available. Again, hydroxyamphetamine, how does it act? It increases the release of noradrenaline. So if it's a post-ganglionic lesion, this nerve ending is involved. So hydroxyamphetamine does not act. But if it's a pre-ganglionic lesion, the nerve ending is intact, and so your hydroxyamphetamine will act. Okay. So let's come to the last group of drugs, which are your parasympatholytics. So these include drugs which produce both mydriasis and cycloplegia. Cycloplegia is paralysis of the ciliary body. This include atropine sulfate, homatropine, hydrobromide, and cyclopentylate hydrochloride, and drugs which predominantly produce mydriasis like tropicamide. So again, mechanism of action parasympatholytic, very simple, competitive antagonism at your muscarinic receptor. Okay, so that's a mechanism of action of a parasympatholytic. Atropine 1% produces mydriasis in about half an hour, which lasts for about 1 week. Cycloplegia occurs in about 1 day and lasts for again 2 weeks. Cyclopentylate, 0.5% and 1% concentrations are used. Again, mydriasis and cycloplegia occurs in about half an hour and it lasts for about 1 day. And with your homatropine 2%, mydriasis and cycloplegia occurs in about 1 hour and lasts for about 1 to 2 days. While with your tropicamide, predominantly mydriasis in half an hour, which lasts for about 4 to 6 hours. What are the uses of your cycloplegic mydriatics? Very commonly used for refraction in younger children, especially those with higher level of iris pigmentation. It's used in the treatment of anterior uveitis. Commonly, homatropine is used, but atropine can also be used. Atropine is also used in the treatment of your ciliary glaucoma to lead to a backward shift of the iris lens diaphragm. And in your amblyopia therapy for penalization, atropine and homatropine can be used. Atropine is favored though, and also for the treatment of accommodative spasms. Contraindication, of course, whenever there is a narrow angle glaucoma or a known hypersensitivity to any of the components, it is contraindicated. Adverse effects include allergic reactions, tachycardia, irritability, hyperpyrexia, and hypotension. Tropicamide does not produce too much of cycloplegia, but there are percentages of 0.5% and 1%, and some studies say that 1% can produce cycloplegia as well, not very commonly used for cycloplegic action. Pupillary dilatation with tropicamide is less dependent on your iris pigmentation, unlike with your atropine and homatropine. And it is used in combination with phenylephrine. Now, phenylephrine is a sympathomimetic. So if you give phenylephrine alone, what happens is the sphincter is still active. So when bright light is shined, the pupil will still tend to constrict. So for your fundus evaluation, we generally go for a combination of tropicamide with phenylephrine. And tropicamide is safer in your cardiac patient. And adverse effects include stinging, sensation, and hyperactivity. Okay, so with that, this topic is complete. Thank you very much.